in this lecture on bacterial infections, we'll be discussing about commonly seen bacterial infections like impetigo, cellulitis, and uncommonly seen but commonly asked in exams like staphylococcal scalded skin syndrome, botryomycosis, ecthyma, gangrenosum. We'll be seeing about the clinical features of these infections. We'll be seeing how to differentiate between them and how are they managed. So let's start the lecture with the Pyoderma. So Pyoderma is the more commonly seen bacterial infections, and let's see how is it classified. Classification of pyodermas. Pyodermas are classified based on the involvement of the air follicle as non-follicular if it does not involve the air follicles, or follicular if it involves the air follicles. Okay. So non-follicular pyodermas can be further classified into localized and spreading infections. The localized can be further divided into superficial and deep. Spreading also is further divided into superficial spreading infection and deep spreading infection. The localized superficial infections include the commonly seen Impetigo contagiosa. Impetigo contagiosa or Bullous impetigo. These are two different superficial localized infections, and the deeper infections include Ecthyma. Okay, and in spreading type, in superficial infection, you see Erysipelas, and the deeper infection is Cellulitis. Okay, this is about non-follicular infections. It can be divided into localized and spreading. The localized can be further divided into superficial and deep. Superficial is Impetigo contagiosa and Bullous impetigo, and deep is Ecthyma. And spreading infections, it could be further divided into superficial and deep. The superficial infection is Erysipelas and deep is Cellulitis. The follicular infection can also be further divided into the folliculitis, that is involvement of the follicles, and perifolliculitis, involvement of the follicles and the adjacent areas. So in follicles, you see superficial folliculitis and Furuncle, and perifolliculitis you see Carbuncle. Okay. In follicular you see folliculitis and perifolliculitis. Folliculitis, inflammation of only the air follicle, whereas perifolliculitis, there is infection of the air follicle and the adjacent areas. And folliculitis, it could be superficial folliculitis, deep folliculitis, or Furuncle, and perifolliculitis, it is Carbuncle. And the organisms causing this infection are non-follicular, could be caused either by Staphylococcus or Streptococcus. Follicular infections are always caused by Staphylococcal. And in spreading type, most commonly caused by Streptococcus. Okay, so among follicular, non-follicular infections also, the spreading type is more commonly caused by streptococcal infections, whereas localized can be caused by Staphylococcus or Streptococcus. So how will the Staphylococcus and Streptococcus look like in gram-stain? So if you see from the picture, you see there are multiple grouped gram-positive cocci. Okay, so this is Staphylococcus. And the next picture, you see multiple positive cocci arranged in chains. Okay, so these are Streptococci. We'll be learning in detail more about these organisms in microbiology. And pyodermas can also be classified as whether it is primary pyodermas or secondary pyodermas. Okay, primary is the de novo infection, and secondary is there are some pre-existing dermatosis, and on top of it you get this superficial bacterial infection. So it could be, the underlying cause could be scabies or pediculosis or tinea, or it could be eczematous disorders like atopic dermatitis. And in any eczematous disorders, there could be secondary bacterial infection, which is called impetiginization. So it's called impetiginization. Okay, it's the infection, the secondary infection of the pre-existing dermatosis. It's called impetiginization. So let's talk about the localized superficial bacterial pyodermas. So superficial, localized superficial, you see there are two infections, Impetigo contagious and bullous impetigo. As we know, like localized superficial infections are caused either by staphylococcus or streptococcus. Okay, and the organism could be staphylococcus or streptococcus. Bullous impetigo is more commonly caused by staphylococcus. Okay, and the age group involved is in Impetigo contagiosa. The age group is preschool or young children. Preschool or young children. Bullous impetigo you see mostly in the infants. Okay, and Staphylococcus in Bullous impetigo produces exotoxin which cleaves the desmoglein 1. So we know desmoglein 1 is expressed in the superficial part of the epidermis. So when it leaves desmoglein 1, there will be subcorneal split. Okay, there will be subcorneal split that will manifest as superficial flaccid bulla. And what are the common sites involved in impetigo contagiosa? It's mostly peri-orificial areas like peri-nasal area, peri-oral area. Okay, peri-orificial areas, and it can also occur over any pre-existing dermatosis. Okay, if the pre-existing dermatosis are over a trunk or limbs, it could occur on those sites also. Bullous impetigo commonly occurs in face, trunk or limbs. Okay, and in impetigo contagiosa you see a thin walled bulla with the surrounding erythema. Okay, you see thin walled bulla around the surrounding erythema. Thin walled surrounding. So these bulla usually ruptures to form thick honey colored crusts. They usually, this bulla will rupture soon to form honey colored crusts like these. Okay, this bulla will rupture to form honey colored crusts. And when you try to remove the crust, you will see erosions. And any superficial pyodermas will heal without scarring, and any pyodermas, if it involves deeper structures, it will heal with scarring. And superficial pyodermas will not have constitutional symptoms mostly, whereas deep pyodermas will have constitutional symptoms like fever, lymphadenopathy, and pain. And bullous impetigo, you have involvement of lymphadenopathy. And mucous membrane is rarely involved. In bullous impetigo, the bulla is a flaccid bulla, which is thicker in compared to impetigo contagiosa. But it will be a flaccid bulla and which will rupture. Okay, rupture soon with surrounding erythema. And this bulla can either extend or either rupture to form thin varnish like crusts. Okay, and lymph nodes are rarely involved, but mucous membranes may be involved. And what could be the complication? It could be eczematization. So we saw what is impetigination. It is secondary infection on pre-existing eczema. And what is eczematization? It is formation of eczema over pre-existing pyodermas. Okay, it could be eczematization, or it could lead to acute post streptococcal glomerulonephritis. And this is caused if the nephrogenic strains of streptococcus cause impetigo. Okay, it is caused by nephrogenic, and bullous impetigo can lead to staphylococcal scalded skin syndrome. Okay, and the pathogenesis is similar. Okay, and in staphylococcal scalded skin syndrome also you have desmoglein 1, which is being cleaved by exotoxin. Okay, so this is about bullous impetigo and impetigo contagiosa, which are localized superficial infections. Next, we'll go to localized deep infection. Okay, it's a non-follicular, localized, deep pyoderma. So, if impetigo contagiosa is not treated properly, it might extend deeper and form ecthyma. Okay, so if impetigo is not treated, it might extend. Okay, and what we'll see is a superficial pus. Okay, pustule on an erythematous base, and which will later rupture to form thick indurated crusted nodules with surrounding edematous area. Okay, you see thick indurated crusted nodules with surrounding edematous area. So where do these ecthyma occur? What are the sites commonly involved? It's usually legs, thighs, and buttock. Okay, these are the common sites involved. Okay, and it's usually caused by staphylococcus or streptococcus, but the organism is mostly streptococcus more than staphylococcus. Okay, and you will have tenderness because deeper structure will have tenderness. So you will have tenderness, and the constitutional symptoms can be present, like fever can be present. Okay, this is all about ecthyma. Let's move on to the spreading type of localized infections. Okay, spreading type of non-follicular infections. Spreading non-follicular. So the causative organism is, for Erysipelas and cellulitis, it is mostly caused by streptococcus pyogenes. Okay, and cellulitis also the most common cause is streptococcus pyogenes, and rarely could be caused by staphylococcus aureus. Okay, so the bacteria could enter through direct route, or could be if the patient has previous lymphedema, there could be secondary bacterial infection which could lead to cellulitis. Okay, and erysipelas, we know it is superficial, and cellulitis it is deeper. Okay, so the level of involvement will be upper subcutaneous tissue plus lymphatics in erysipelas, whereas the involvement in cellulitis would be deeper subcutaneous tissues. And what you will see edematous plaque. Okay, and the sites commonly involved in erysipelas are face, whereas in cellulitis is more commonly caused in legs. Okay, And you can see from this picture, these are well defined erythematous edematous plaque, and you see the shininess. Okay, and whereas here in this picture you can see these are ill defined erythematous edematous plaque over the legs. Okay, so the margins will be well defined in Erysipelas, whereas in cellulitis it will be ill-defined margins. And what you see? Erythematous, edematous plaques. Since this upper subcutaneous tissue and lymphatics are involved, it could lead to superficial vesicles. Superficial vesicles. Okay. And there can also be pudy orange appearance because the involvement of the lymphatics. And in cellulitis, you will see bulla which ruptures to form ulcer. Okay. And since they are spreading, okay, since they are spreading pyodermas, they will have pain will be present, and both erysipelas and cellulitis will have involvement of lymphadenopathy. Okay, and as you can see from the picture, there is involvement of the ear. Okay, if cellulitis occurs over the face, then how will you differentiate erysipelas and cellulitis? Okay, in erysipelas there would be involvement of the ear. Okay, whereas in cellulitis there would not be involvement of the ear because there is no deeper subcutaneous tissue in ear. So this difference is called million ear sign. Okay, this is called millions ear sign. And mostly these infections occur in immunocompromised patients or in patients with history of trauma. And let's move on to the follicular infections. If it involves the follicle, it's called folliculitis. So involvement of the follicle is called folliculitis, and it could be caused by either infections or it could be caused by mechanical trauma or it could be caused by chemicals. Infections are most commonly caused by Staphylococcus aureus, and chemicals are usually caused by uh, exposure to mineral oils. Okay, mechanical folliculitis can occur because of shaving or waxing. Okay, either because of shaving or waxing. So shaving most commonly occurs in the beard area, and waxing it most commonly occurs in the arms and legs or the limbs. Okay, if suppose there is involvement of the follicle in the deeper area also, that is deep folliculitis. If occurs deep folliculitis in the beard area, it's called psychosis barbae. Psychosis barbae. That is deep folliculitis of the beard area. So what you see in folliculitis, you see dome-shaped and dome-shaped follicular pustules. You can see these are the hair follicles, and surrounding that follicle you see the pus. So that is the involvement of the follicles called folliculitis. Okay, that's why it's folliculitis. Dome-shaped follicular pustules. So in deep folliculitis, what happens is deep folliculitis in the berry area, the deeper folliculitis will coalesce to form an erythematous plaque with multiple pus points. Okay, it would form erythematous plaque in the mostly in the beard area, mostly in the chin area. Okay, let's next move on to the furuncle. Furuncle is involvement of the adjacent follicles and the adjacent areas. Okay, and it's a deeper involvement. Okay, it is also deeper involvement of the hair follicle and the adjoining area. And where would you get these furuncles? These furuncles you would get it mostly over the limbs. Okay, and what you see, there be one or two tender erythematous indurated nodules with pus point. Okay. So since there is deeper involvement, patient will have throbbing pain, and that could be fever and lymphadenopathy. Whereas in carbuncle, it is deeper involvement of the contiguous hair follicles. That be involvement of multiple hair follicles. Okay, deeper involvement of contiguous hair follicles. And what are the more common sites for carbuncle? It will be over the back and neck. Okay, these are the common sites for carbuncle. And what you see, you would see a tender lobulated, because multiple contiguous follicles are involved, so tender lobulated indurated nodules, nodular plaques, okay, with pus discharge from multiple openings. This is because multiple hair follicles are involved. And this carbuncle occurs in the pre-existing diabetic patient. Okay, patient is a diabetic, then they are more prone for deep infection of contiguous hair follicles, that is carbuncle. Can occur in immunocompromised patients. And since there is deeper involvement, you will have tenderness, and you will also have throbbing pain, and you will have constitutional symptoms. So you see in Furuncle, there is deeper involvement of the hair follicle, but as in carbuncle, you will see deeper involvement of the multiple contiguous hair follicles. So since there is involvement of one follicle, you will see a single pus point, whereas in carbuncle, you will see pus discharge from multiple openings. And both are deeper involvement. Okay. And furuncle is common over the limbs, whereas in carbuncle, it is common over back and neck. And both will have throbbing pain and fever and lymphadenopathy. So next, we'll talk about staphylococcal scalded skin syndrome. This is rarely seen, but very commonly asked in exams. It's also called Ritter's syndrome or Ritter's disease. Okay, so it's not Ritter's. Ritter's disease is reactive arthritis. Okay, this is Ritter's, Ritter, Ritter's disease, and this is caused by staphylococcus, as the name suggests. Okay, as the name suggests, it's caused by staphylococcus. So, which age group is predisposed to staphylococcal skeletal skin syndrome? It is usually infants, more commonly within a week after birth. Sometimes adults are also involved, very rarely. Okay, very rarely. So, who are prone with adults with renal failure? So, these staphylococcus produces exotoxin. And this exotoxin cleaves desmoglein 1. Okay. So desmoglein 1 is expressed in the upper part of the epidermis more, and since there will be cleavage of the desmoglein 1, there will be split in the upper epidermis. That is, the patient will have subcorneal split. Okay, and this pathogenesis is more or less similar to pemphigus foliaceus. In pemphigus foliaceus also we saw that be skin involvement and there won't be any mucous membrane involvement. So in skin, what you see, you will see a tender rash starting from face or flexures. Okay, tender rash starting from face or flexures, which will form a bulla. Okay, and if you try to do Nikolsky test, Nikolsky will be positive. Nikolsky sign will be positive. Okay, and there will be superficial peeling of skin. Superficial peeling of skin. So because of superficial peeling of the skin, there would be high chance of secondary infection, and there will be water loss and electrolyte imbalance. So there will be dehydration, there will be electrolyte imbalance, and because of these factors, The patients are prone for sepsis, and because of dehydration, it could lead to renal failure. Okay, these are the complications of staphylococcal scalded skin syndrome, and this mostly heals within 2 weeks. Mostly heals within 2 weeks. An important point is no mucous membrane involvement. And this staphylococcus, its the infection would be in a different focus. Okay, like in external, then like in the middle ear. Okay, the focus could be away from the site. So focus would be at the middle ear, like, okay, or it could be an impetigo. This staphylococcus in these focus will release the exotoxins, and these exotoxins will migrate and they will cleave the desmoglein one. Okay, the focus will be at the somewhere else. So if you do culture, you won't have any organisms. Okay, culture of the blister fluid will be negative because this is caused by toxin, not by the bacteria itself. Okay, the culture of the fluid, blister fluid, would be negative. And what would you see in histopathology? You would see the subcorneal split plus acantholysis. And how would you manage these patients? These patients, these infants need supportive care because the skin, the superficial layer is lost and they are prone for infections and dehydration and electrolyte imbalance. So it gives supportive care to correct all these things. Supportive care is important. Along with that, you can give antibiotics if they are methicillin sensitive Staphylococcus aureus. You can give cephalosporins, third generation. Okay. If they are methicillin resistant Staphylococcus aureus, you can give vancomycin. But supportive care is very important. So this is about staphylococcal scalded skin syndrome or Ritter's disease.